in starting this. Yes. Good evening, everyone. And we are all here today to hear from one of the experts in dog bite and related animal bites. And we have none other than Professor Reeta Mani Madam with us. Reeta Subramaniam Mani Madam is a very simple person. I have met her in a couple of conferences. I've heard her enlightening talks, and she heads the Department of Neurovirology at NIMHANS, the prestigious institute. And Madam is a very senior researcher as well, closely collaborating with WHO and such other agencies. And she has 81 index publications. She's a very humble human being. She didn't even give her CV. I searched through the net and also chat GPT to find out more about her. And her major research areas being, apart from rabies and neurovirology, it's been in viral encephalitis. I would request the audience to kindly mute. I know the audience are pouring in, but we want the whole session to have its code of conduct. It's a gentle request. Kindly note that please put your speaker off unless you would want to ask a question. Thank you. Madam has over 81 index publications. I don't know, she would have added more. This may be old data. Apart from rabies and neurovirology, Madam's interest also is in viral encephalitis, CNS, other CNS infections and diagnostics. And she has many notable publications among human rabies survivors in India, an emerging paradox, studies on SARS-CoV-2 Delta variant epidemiology in India, and so on and so forth. All of us know that we need to know about rabies because 97% of human rabies death in India are caused by dog bite, and India carries a large share of global rabies burden, and nearly estimated 20,000 deaths annually. Madam will correct me if there are any data variations. And though we have an annual animal bite incidence of about 1.7%, a majority of them being by dogs, around 92%, and higher bite rates in children and in rural population. We have several reasons, and we would request Reeta Mani Madam to go ahead and enlighten us about this very interesting topic, because we as primary care providers working in clinics, working in health centers, working in diagnostics, working in hospitals, whether secondary, tertiary level, or even quaternary level, there's a lot of fear when we see very higher category dog bites. And I think after today's session we'll be more confident to manage dog bite or any other animal bites. Over to you, Madam.
Yeah, thank you, Dr. Soumya. A very good evening to everybody. At the outset, I'd like to thank Dr. Soumya for this kind invitation and the introduction, despite me not sending her my CV. But yes, I'm really very happy to be talking to your group, and I request all of you to please ask me questions. I'll definitely keep some time, and even if we overshoot the time, I am okay with it, because the purpose is to answer all queries. This is a very, very important group for me to create awareness also for many things that we will see now. So I'll share my slides now.
Yes, ma'am.
Yeah, are my slides visible, Dr. Soumya?
Yes, ma'am. It's visible.
Yeah, and I'm audible, right?
Yeah, yes, you're clearly audible.
Yes. So let me start then. So this is the topic given to
Yes,
me
ma'am.
by
Sure.
Dr. Soumya. Uh, Before we see the preventive aspects, let me just give you a brief overview of rabies, which I'm sure all of you know. So the disease rabies is an acute, progressive, and fatal encephalomyelitis. And the infection is caused by viruses from the genus Lissa virus. The main virus causing the disease rabies is also called as the rabies virus. Now, as Dr. Soumya mentioned, there are about 61,000 people dying of rabies every year worldwide, and most of them happen in Asia and Africa. Now, most of them, as she again rightly mentioned, are mediated through rabid dog exposures. Now, India has almost 1/3 of the global burden. That is, India reports 20,000 human rabies deaths, which is 1/3 of the global deaths and almost 60% of the deaths that happen in Asia. But there is some good news. A recent burden assessment, which was done in our country, has reported just about 6,000 human deaths annually. So that's a good news that the human rabies deaths are decreasing. But even with this number, India remains the country with the highest burden anywhere in the world. So how is the disease transmitted? We must remember that the most common mode of transmission is through rabid animal bites or other exposures. I have put in other ways of transmission as well, but remember they are very, very rare modes of transmission, like uh, through virus loaded aerosols in laboratory workers or people who uh, go into caves which are inhabited by rabid bats, or handling or skinning of infected animal carcasses. Uh, Also, rabies has been reported to be transmitted through corneal or organ transplants from infected patients. We must know that the rabies virus cannot enter through intact skin. It can only enter through broken skin, but it can enter directly through the mucous membranes of eyes, nose, or the oral cavity. Now, the picture of the virus that I have put below, just remember, uh, of course, we all have learned it in our undergraduate class that true to its reputation, the rabies virus is bullet shaped. It's a RNA virus. And how does it actually cause disease? So the rabies virus is a highly neurotropic virus. So it is like almost born with an ambition to reach the brain of the host it infects, whether it's animals or humans. So if you can see, uh, wherever the animal bites, the virus is generally shed in the saliva of a rabid animal. Again, remember the animal has to be rabid to be able to transmit the infection to human beings. It is not that any animal can transmit. So the virus is shed in the saliva of a rabid animal. Now, when there is an animal bite, the virus is deposited at the site of the bite through the animal's saliva. There is some local replication of the virus that happens at the site of the bite. And then this virus, which is really very smart, travels only through the nerves. So it enters the peripheral nerves and then via the spinal cord, it reaches the brain. Remember, unlike other pathogens, there is no viremia. So you will not find the virus in the blood. It only travels to the nerves until it reaches the brain. And therefore, now until it reaches the brain, because there is no viremia, it is not found anywhere other than the nerves. The body does not even recognize that there is a foreign body or a foreign infection, like you see with other pathogens. And therefore, there is no immune response against the virus as well. When the virus reaches the brain, I said that it's highly neurotropic. It loves neurons. It multiplies in the brain. And then that is the time when the virus is multiplying in the brain is when a person becomes symptomatic. Either an animal or a human being becomes symptomatic, by which time it is too late to do anything. Now, after it multiplies in the brains, it spreads to virtually all innervated organs, again through the nerves. So I hope now this part is clear, because that will help you understand the preventive measures. The
Yes, ma'am.
clinical course in brief, uh, the incubation period. Now, after an exposure, whether it's a bite or a scratch or uh, exposure of the mucous membranes to secretions, infected secretions like saliva or other biological fluids, the incubation period is usually 20 to 90 days. This is the most common incubation period. So you can remember it as 1 month to 3 months. Now, yes, we all know that the incubation period can vary from less than a week to even more than a year, but that is extremely rare. In practice, what we have seen is generally it is between 1 month to 3 months. We also see some cases between 3 months to 6 months. But incubation periods beyond 1 year or below 10 days are extremely rare. The shortest incubation period that I have seen is around 6 to 7 days. Now, after this incubation period, the patient can manifest in two classical forms. One is the furious form, or it's also called as the encephalitic form in human beings, which presents with classical hydrophobia and the classical signs and symptoms which we've all read in our undergraduate days. The other form is the paralytic form, which has a slightly more insidious course than the furious form. Now, these patients will present initially with weakness of the bitten limb, which then progresses to paralysis of that particular limb and then to other limbs as well. Now, in both these forms, they progress ultimately, eventually to coma and death within 1 to 7 days. Usually, we see the paralytic form of cases survive slightly longer than patients with the furious or the encephalitic form of rabies. Clinical management, I have just put to tell you that there is no known proven specific treatment for rabies anywhere in the world. So it is only supportive care, mainly palliative care, that any patient with a confirmed diagnosis of rabies has to be given. Usually, such patients have to be treated in a quiet, dark, draft-free room, because any light, sound, or even drafts of air tend to irritate the patients and make them more agitated and aggressive. And therefore, supportive therapy includes sedation, rehydration, and analgesics or antipyretics wherever required. Usually, any invasive procedures have to be avoided in such patients. Now, coming to the main aspect for which we are here today is the prevention. Now, because we know that rabies is almost always fatal, but it is almost 100% preventable, even after an exposure. So, this is the best part about the disease, which is really a very agonizing disease, though it is such an ancient disease. So, this group of people that I'm talking to, y'all are the ones who can help bring down the burden in our country, and that is with prophylaxis. So we can prevent rabies either by post-exposure prophylaxis, which is given immediately following a potentially rabid exposure. Also, it can be prevented with pre-exposure prophylaxis, which I'm going to talk about. which not many even medical professionals are aware about. So this is something which also I want to talk about to this group. Now, post-exposure prophylaxis is the one which we are going to deal with first. So if a bite victim arrives at your clinic, what are the questions that you need to ask them? So the first is, when did the bite or the exposure happen? Now, remember, a bite from any animal is dangerous, but a scratch also is equally dangerous. Animals like dogs, cats, they lick their paws, and therefore the saliva is deposited, it is present on their paws as well. So when they scratch, the saliva can infect human beings, and therefore both bites, scratches are equally dangerous. Also, any splash of a animal saliva onto the eyes or oral nasal mucosa also is dangerous. So you need to ask, when did this bite or exposure happen, to know that how much time has passed after the exposure. Remember, though rabid bites are not a medical emergency, it is a medical urgency. And the earlier you start post exposure prophylaxis, the better it is for the patient. And therefore, it is important to know when this exposure has happened. Having said this, even if a patient comes to you, say, after 1 week of an exposure or 1 month after an exposure, still you can start the post exposure prophylaxis. Because the incubation period of rabies is usually quite long, we can always give that benefit to the patient and start PEP even if he comes late to you. The second question that you must ask is, what is the type of exposure? Whether it's a bite, it's a scratch, whether it's a mucosal exposure or any other exposure. And this is something which you will have to examine yourself as well. Then you should also ask, what was the animal which bit the patient? Whether it is known or unknown. We do get some cases, say students from hostels who come and tell us, I was bitten at night on my toe. Probably it was a rat, but I do not know what was the animal. So there are incidents where the person may not even know what was the biting animal. Uh, Also, it is important to ask whether it was a pet animal or a stray animal, especially dogs, whether it is a pet dog. And if it is a pet cat or a pet dog, also ask whether it is vaccinated for rabies. You also need to examine all sites. Now, particularly in children, see, the child may point to a particular site of bite, but you will have to examine the entire body to see whether there are any other scratch or bite marks. That is extremely important, because later I'll tell you that when we give rabies immunoglobulin, each and every small wound has to be infiltrated with the rabies immunoglobulin. And therefore, we must examine the entire body, particularly in children. Then you also must, if the patient, say, has come to you after a few days, you must ask whether there was bleeding at the site when the exposure happens, because that will help us in categorizing the wound. You must also ask them whether they washed the wound uh, immediately following the exposure, or whether they applied anything. It's very common in India for people to apply turmeric, chili powder, lime, neem, even coffee powder, so many things at the site of the wound. So you must ask these details from the patient. Another important question is, you will ask them whether they have taken rabies vaccination anytime earlier. There are many animal lovers who would have already got several exposures earlier and they would have taken rabies vaccination. So that will help you determine what is the regimen of post-exposure prophylaxis you will give them. Now, after you get all the answers to these questions, you must first categorize their exposure depending on uh, all the questions that I had put earlier in the slides. So you can see these are the three categories according to WHO, category 1, 2, and 3. Category 3 is the most severe form of exposure. Category 1 is when somebody just comes and tells you that a dog licked me, or I just fed an animal. So, as I said, the virus cannot enter through intact skin. And therefore, if you are sure that wherever the lick happened, there was no cuts or abrasions, then you are sure that this particular case does not require any post-exposure prophylaxis other than thorough washing of the exposure site. Category 2 involves nibbling of uncovered skin and any minor scratches, abrasions without bleeding. So this category is a minor category. It requires thorough washing of the exposed area and rabies vaccines. The third and the severe category bite is single or multiple bites or scratches or even licks on broken skin. So this is something you all must remember, that licks on broken skin are a serious category. Also, contamination of mucous membranes with saliva of potentially rabid animals is also a severe category. In India, bites from any wild animals are also categorized as a category 3 because it is very rare that wild animals become uninhibited and can bite a human being. And therefore, unless proven otherwise, we treat it as a rabid animal. Now, in this category, we have to administer both vaccine as well as rabies immunoglobulin, in addition to thorough wound washing. So I hope all these categories are clear. If there are any doubts at the end of my talk, we will take questions. Now, so now you all know that the post-exposure prophylaxis is a three-pronged approach consisting of wound management or first aid, second, active immunization with rabies vaccines, and the third is passive immunization with rabies immunoglobulins. And as I have said earlier, there is no time limit to initiate PEP. Of course, the more the delay in initiating PEP, the risk of acquiring rabies in people increases. You must tell them clearly. But there is no reason not to start PEP like ours, which is endemic for rabies. Now, this is again a question that we frequently get. Which are the animals that can transmit rabies to humans? Now, all mammals can get rabies and can potentially transmit rabies to human beings. This is something we all have to remember. As Dr. Soumya mentioned, dogs are the most common vector transmitting rabies to human beings, not only in India, but in Asia and Africa, wherever rabies is endemic, and most of the human deaths happen. But cats, monkeys, mongoose, wild animals, all these have been reported to transmit rabies in human beings. Also, cattle, cows, buffalo, sheep, goats, all of these can also get rabies and can transmit rabies to human beings. Now, usually it is said that small rodents like house rats, mice, squirrels cannot transmit rabies, and therefore the risk is not very high. Now, I've put bats in red here. That is because we know that bats can transmit rabies to humans. In fact, in several countries like the United States, in Europe, in even Australia, there are bat-borne lyssaviruses which have transmitted rabies to human beings. But in India, there is no adequate evidence to suggest that bats can transmit infection to human beings. And therefore, the current national guidelines do not recommend post-exposure prophylaxis following bat exposures. But having said this, you have to treat each case on an individual basis depending on their history. So if somebody says that a rodent, a big rat or a bandicoot bit me, it is always better to err on the side of caution and offer post-exposure prophylaxis. Even bats, if somebody has had a clear exposure to bats, though the national guidelines do not recommend PEP, on an individual basis, you can still recommend PEP, because remember, it is also a condition where the bite victims are extremely anxious, and therefore giving PEP will also alleviate their anxiety, in addition to giving them protection for any future exposures as well. Now, the first step of post-exposure prophylaxis is wound management, which is often ignored not only by lay people, but us from the medical community as well. Remember, by washing thoroughly the area of the bite, we are mechanically removing the virus which is deposited at the site of the bite before it enters the nerves. This step, this simple step itself can reduce the risk of acquiring rabies by about 50 to 70%. So if the person who comes to you has not washed, or even if he has washed, the first thing y'all will advise is thorough flushing under running water with water alone, or if soap is available, with soap and water. And this should be for 10 to 15 minutes. So in fact, we have recommended now that most anti-rabies clinics should have a tap where the bite victims can thoroughly wash. So this is something, if you all are working in slightly bigger hospitals and not a small clinic, where you all can have a facility for wound washing, please do consider, because that is the most important yet the most simple thing that anybody can do to reduce the risk of rabies. If any disinfectants are available, you can use, but otherwise it's not mandatory. But things like turmeric, chili powder, anything else should be completely avoided. Now, why is that? Any of these substances can irritate the bitten area more, and by traumatizing that area can expose the nerve endings. And we are in fact facilitating entry of the virus by doing so, which is why it should be avoided. That is the same reason why suturing also is usually avoided in rabid exposures. Because again, the process of suturing, we are traumatizing the tissue even more and exposing the nerve endings. So unless suturing is mandatory to probably achieve hemostasis, it should be postponed. If it is mandatory, it cannot be avoided because the wound is very large, it is bleeding. In such cases, you must first infiltrate the rabies immunoglobulin at the site of the bite, allow it to diffuse, and then suture. Initially, you can do loose sutures, and probably after about, say, 2 to 3 weeks, you all can then apply secondary sutures. Wherever indicated, you can also give antibiotics or tetanus as indicated. The second step of post-exposure prophylaxis is rabies vaccines. Now, this is a question many people ask us. What are the side effects? Are there any serious side effects following rabies vaccines? Yes, so more than 25 years ago, when we had the nerve tissue vaccines, which was also called as the Sempill vaccine or the sheep brain vaccine, that did have many side effects, including neurological complications. But since 2004, these vaccines are banned almost in the entire world, including in India. Now, the currently available rabies vaccines are all cell culture based vaccines in India, and they are all equally safe and effective. So the two most common types of cell culture based vaccines we get in India are a purified chick embryo based cell vaccine and the purified Vero cell vaccine. Both these are equally safe and equally efficacious. Now, what is the route of administration of rabies vaccines? It can be given both by the intramuscular route as well as the intradermal route. Again, both these routes of administration are equally safe and equally efficacious. So let us now know what is the dose for intramuscular as well as intradermal administration. Now, a rabies vaccine comes only as a single dose vial, that is single intramuscular dose vial, which can be either 0.5 ml or 1 ml depending on the brands. Most brands now have a 1 ml vaccine, but some brands come as 0.5 ml as well. So one intramuscular dose is the entire vial of the vaccine after reconstitution. But what is the dose if you give it intradermally? You give the same vaccine intradermally, but the dose is only 0.1 ml, irrespective of whatever is the intramuscular dose. So you can see that the intradermal dose is just 1/5 or 1/10 of an intramuscular dose. It is so cost effective and it is equally safe and efficacious. So why are all of us not using only the intradermal route? That is because there are certain challenges. Now, most of the public hospitals give the rabies post-exposure prophylaxis only by the intradermal route because as you can see, it is cost effective. It saves a lot of doses also. But in private setups, it is generally not preferred because once this vial is opened, it has to be used up within 6 hours. Otherwise, it has to be thrown away. So if you don't have many footfalls, you will anyway not be able to use all the doses. Therefore, people prefer to use it through the intramuscular route where you inject the entire vial. Also, there is a lot of confusion between the intramuscular and the intradermal regimens. Administration in children might be slightly difficult when you use the intradermal route because it is not as quick as an intramuscular injection. So if children, if they are not steady, especially younger children, it might be difficult to give the intradermal because as you can see in the picture, generally the intradermal vaccine is given using a tuberculin or insulin syringe and it has to be held almost parallel to the skin, like the way you give a BCG vaccine. Now, what are the sites for vaccination? This is also very important when it comes to rabies vaccines. The intramuscular rabies vaccine must be given in the deltoids. In children younger than 2 years, you can still give it in the anterolateral part of the thigh. Intradermal, you can again give it on the deltoids. You can also give it on the anterolateral thigh as well as suprascapular regions because usually intradermal doses are multiple doses and therefore you can use multiple sites. The most important thing that you all must remember is that intramuscular rabies vaccines should never ever be given in the gluteal region. So that's an absolute no-no. Now, why is that? Because many vaccines and many other injections are given in the gluteal region. The rabies vaccine, unlike other vaccines, we want it to be absorbed very quickly and we want the immune response to be triggered very fast to be able to protect the person from rabies. And since there is the adipose tissue in the gluteal region, the absorption of the vaccine is slowed down, which also will slow down the immune response. And that is why if you even come to know that somebody has taken the first dose, say on the gluteal region, you should consider it as null and void and restart vaccination. So this is a very important thing to remember. Now coming to the regimens. So there are multiple regimens which you can use, but I am going to just put the ones which are nationally recommended and which most people are familiar with. So I feel that most of you can follow, in fact, all of you can follow these regimens. These are as per the national guidelines. So this regimen is for people who have never been previously vaccinated, or it's called a primary intramuscular regimen. It is also called as the SN regimen, which consists of one dose intramuscular given on 5 days, which is day 0, day 3, day 7, day 14, and day 28. Okay. So 5 dose regimen, one dose on each of these days. What is the intradermal regimen, which is used in India? In most of the public hospitals, if you see, this is the regimen they follow, and therefore you should know that this is what is followed so that there is no confusion. It's called as the updated Thai Red Cross regimen, which consists of two-site intradermal. Okay. So you give 0.1 ml each on each deltoid. So 2 pricks on days 0, 3, 7, and 28. So the intradermal regimen is only a 4 days regimen. Day 14 is omitted here. Whereas you have seen the intramuscular regimen, it is on all 5 days. Okay. But the intradermal is two-site on each of these days. Now, what do you do in people who have been exposed earlier, have taken rabies vaccine earlier, and have come to you again with a re-exposure? In such cases, you have to give only 2 boosters on day 0 and 3. It can be a single dose, either intramuscular or intradermal. Now, the best part is there is no passive immunization required. That is, rabies immunoglobulin is not required if the person is vaccinated any time previously in life. And when I say rabies vaccination, it should be a complete either post-exposure or pre-exposure regimen. So it's not that somebody has taken one dose earlier, you consider it as complete vaccination. Only if they have a documented proof that they took all the vaccines during their earlier exposure, then this is the regimen you follow. If you have any doubt, as I said, it is better to err on side of caution and give all the doses. If the bite victim is not sure, they don't have documentation, then you can never take the risk. So if a re-exposure happens within 3 months of taking a previous rabies post-exposure prophylaxis vaccination or pre-exposure prophylaxis, then you don't have to give any booster. Only if a re-exposure happens 3 months after the previous vaccination, then you need to give these 2 boosters and no immunoglobulins. I hope this is clear because this is where we get a lot of questions. Now, these are facts that you all have to remember. What is day 0? Because we say day 0, 3, 7. Day 0 is not the day of the bite. It is the day when the first dose of vaccine is given. So ideally, day 0 should be same. The first dose of vaccine should ideally be given on the day of exposure. But we know that that doesn't happen in practice. So say if the patient comes to you 3 days after the bite, you will give the first dose on the 3rd day, but you will call that as day 0 and then calculate day 3, 7 from that day. Also, we must remember that the vaccine dose and regimen is the same for any age group, a newborn, elderly, immunocompromised, anybody, because we have seen cases where children have developed rabies despite PEP, and only later we realize that because it's a pediatric age group, only half the dose was given, which is really very sad. Also, we must remember that post-exposure prophylaxis is life-saving, and therefore there are absolutely no contraindications. Pregnancy, lactation, immunocompromised status, very elderly, no contraindications for rabies post-exposure prophylaxis because it is a life-saving therapy. And the last point I've already mentioned, rabies vaccines should never be given in the gluteal region. Now coming to the third pillar of post-exposure prophylaxis, which is passive immunization. Now, we give passive immunization in category 3 wounds only because they are the severe category wound. We also give rabies immunoglobulins in category 2 exposures in people who are immunocompromised due to various reasons. They are on cancer chemotherapy, they are on long-term steroid therapy, they are HIV patients with low immunity, and so on. So this is an additional protection because we know that the active immune response following vaccine takes about 1 to 2 weeks for the antibodies to appear. And therefore, we are using a passive serum derived from either horses or humans, which have produced antibodies in the serum. And that is why we are using this serum locally at the site of the bite to neutralize whatever virus is present there. Now, what are the products available for passive immunization? Equine rig, which is produced in horses. The dose is 40 international units per kg of body weight. Equine rig is produced in India. It is more cheaper than human rig, and it is equally efficacious. There are some concerns of anaphylaxis, but it is an extremely rare complication because it's a heterologous serum. Otherwise, the general safety profile of equine rig is been quite good in India from the experience of past so many years. Human rig is safer, but it's not produced in India. So whatever products of H rig we have are imported products, and therefore they are 10 to 20 times more costly than equine rig. Now, both these products, we always face a shortage in the country because there are limits for manufacturing, both in horses as well as humans. So recently, we have products which are called as rabies monoclonal antibodies, which are launched in India for the first time anywhere in the world. One product is Rabies Shield by Serum Institute, and the other is Twin Wrap by Zydus. And I've put the doses there. The dose is per kg body weight. And remember, whatever doses we are mentioning, these are the maximum dose that you can go. So you should not exceed this dose. But if the wound is small, you can always use a lesser amount of the immunoglobulin. So as I said, it is mandatory in all category 3 exposures and also in category 2 exposures in immunocompromised patients in addition to vaccines. Rabies immunoglobulins or monoclonals have to be administered only once, unlike vaccines which you give several doses. And preferably, this has to be given within 24 hours of the exposure. You can give it at the same time when you give the first dose of the vaccine. But if you find some patient coming to you who has taken the first 2 or 3 doses of vaccine but had not received immunoglobulin, you can still give the rabies immunoglobulin within 7 days of the first vaccine dose. Now, beyond that, giving immunoglobulin is not of much use because active immune response triggered by the vaccine will already be there, and this might only interfere with that response. Now, how do you give rabies immunoglobulin? You calculate the maximum dose of rig based on the body weight of the person, and then the maximum volume of the rig that is anatomically feasible should be infiltrated locally into and around the wound sites. Now, you might be remembering earlier recommendations which said that give 50% intramuscularly and 50% locally. So please remember that guideline has changed completely now. Now, only local infiltration is mandatory. If at all any amount of the rabies immunoglobulin after giving locally is left over, you can inject it intramuscularly. But otherwise, you can use it for some other patient, because giving it intramuscularly affords no additional protection. So this is something also which you all should know. So there are only certain situations where you have to give the rig intramuscularly, and that is where there is a likelihood of many additional small wounds which you are unable to see, or if there is exposure to bats, or there is a mucosal exposure or non-bite exposures, or if the exposure is through aerosols. In such conditions, we cannot give local rabies immunoglobulins, and therefore you can give it intramuscularly, but we cannot be sure whether it will have 100% effect in preventing rabies. Now, I have just 2 more slides left. I'm talking in brief about pre-exposure prophylaxis. So pre-exposure prophylaxis can be given to people who are at high risk of rabies because of their occupation, like veterinarians, animal handlers, even say travelers coming from, say, the United States or Europe, which are rabies free. When they travel to endemic countries like India, Thailand, they are advised pre-exposure prophylaxis. Now, children in rabies endemic areas like us are also considered to be highly vulnerable and at high risk of rabies. And yet, we never ever recommend pre-exposure prophylaxis in our country. If at all I want you all to take some message after my talk, is that at least all of you, please vaccinate your own children against rabies, because each one of us, we know how many stray dogs are there, right? All of us encounter. All of us are at risk. So definitely we adults can also take, but children are highly vulnerable. So please give them pre-exposure prophylaxis. And if any of you are pediatricians in this group, whenever you advise other universal immunization vaccines, please at least offer this option to parents, because the Indian Academy of Pediatrics also classifies the rabies vaccine as a optional vaccine. So this is something that you must spread awareness about. So what is the regimen you use for pre-exposure prophylaxis? It is again a single dose intramuscular or intradermal just on 3 days. Day 0, 7, and 21 or 28. It's as easy as that. Now, following a pre-exposure prophylaxis, now say you give these 3 doses to your children. Do you need to give boosters? No. There are no boosters required in the entire lifetime. Even if their titers, the antibody titers may fall down, their memory B cell response is there for a lifetime. So only if your child gets any exposure anytime in life following your pre-exposure prophylaxis, at that time you have to give only 2 doses, day 0 and day 3. And best part is they do not need passive immunization, which is extremely painful, costly, and may not be available whenever there is a bite. So we also do post-vaccination titers. WHO recommends a titer of 0.5 international units or above, which is suggestive of protective titers. But this is not recommended in healthy individuals. It is only recommended in immunocompromised individuals to see whether they have adequate antibodies following vaccination, where we recommend that sero monitoring should be done for titers. If the titers are found to be lower than 0.5 international units, then we recommend additional boosters for them. This is the last slide. So y'all might ask, say, if a bite victim comes to me and I give everything timely, appropriately, and adequately, wound washing I do properly, I give them vaccines, I give them immunoglobulins, can it still fail? Can the patient still develop rabies? So this is something in news nowadays, and people say rabies despite post-exposure prophylaxis. Is there a vaccine failure? So remember, true post-exposure prophylaxis failures are extremely rare because the currently available vaccines and immunoglobulins are really very good. So when can this happen despite post-exposure prophylaxis? If somebody has very serious bites, multiple bites, especially on areas which are highly innervated, like the face, neck, scalp, fingers, these are all highly innervated areas. And if the bites are so deep that the virus is directly inoculated into the nerves, in such cases, we do see failures. Because once the virus enters the nerves, nothing can be done. We can only, both the vaccines and immunoglobulins can prevent the virus only until it enters the nerves. So, true PEP failures are extremely rare, but most of such failures, what we see in our experience, they are not true PEP failures. They are because there are serious deviations in the PEP protocols that we have seen. That is incorrect advice. The regimen is wrong. Wound care is never done. Suturing of the wound is done without giving rabies immunoglobulin. Then PP initiation is delayed. Dose of the vaccine is not correct. Site of the vaccine is wrong. It is all 5 doses are given in the gluteal region. Or RIG is given, but it is given only intramuscularly. Locally, it is not given at all. Or we see most cases RIG is not given at all. Just give vaccine and send the patient off. So this is something I want to share with your group. I feel that somewhere we as a medical profession are responsible for at least some of the rabies deaths that are occurring now in India. And this is a message I want all of you to carry. And I am now, if of course Dr. Saumya says there is time, I am open to questions. In fact, I will be happy to answer any questions.
Thank you, Rita ma'am, for such a crystal clear, simplified explanation of your expert topic. And at the same time, I know there are a lot of questions which will pour in. I acknowledge the presence of our national president, Colonel Dr. Mohan Kubendra, here to the webinar. So now getting on to the questions, actually. Um, Scratch with minor bleed is category 3. Patients coming next day with wound already healed. How to give immunoglobulin?
Yeah, so very good question. Again, for categorization, let me simplify for all of you because this is always a confusion. So remember, between category 2 and 3, what is the difference? Even if there is one drop of blood, it is category 3. It need not, the blood need not flow. Even if you can see a drop, it is category 3. Okay. And how do you differentiate between category 1 and 2? So basically, you want to know whether there is a breach in the skin. You can just take a spirit or alcohol swab and try to just wipe the area which is exposed. If there is burning that the bite victim feels, there is a breach in the skin, and that is category 2. Now, coming to your question that when the patient comes, if the wound is healed, still you can give at the site of the bite, even if the wound is healed, you can give the rabies immunoglobulin.
Okay. So coming to the next question, up to what interval post exposure wound washing and rig is beneficial?
Yeah, so as I said, see, if post-exposure prophylaxis is never started, say a patient comes to you 1 month after the bite and says, I got to know now, I never took, I was bitten by a dog 1 month ago. You can still do all the steps. You can still do wound washing. You can still give vaccines and you can still give RIG. If you can see the site of the wound, you can still give RIG. But if the patient has started vaccination, then you can give the rabies immunoglobulin only within 7 days of the first dose. Because otherwise, it is going to interfere with the active immune response. So I hope I'm clear.
Yes, ma'am. And Dr. Colonel has a question. Over to Colonel himself.
Hello.
Yes.
Yes, sir, we can hear you well.
Good evening. Good evening to all of you. And really, such a extremely useful topic. And thank you, AFPI Karnataka, for organizing this. And Dr. Rita, excellent presentation. This is one topic I think all the practitioners should be thorough with various scenarios we get. Someone coming and saying that we just had a leak, should we take vaccine? Someone saying that the owner is saying that the dog is vaccinated, so why should the person bitten be vaccinated again? So such queries keep coming in the practice, especially in some of the colonies these days in urban area. Some of them are dog-friendly colonies. Like my own colony, we have about 600 houses, and at least every second or third house has a dog. So at least in my practice, I must be giving at least 5, 6 course of vaccination in a month. Okay. I have two queries. In fact, it would be a great idea to take this presentation to these RWS, the Resident Welfare Organization. In fact, I was thinking myself that I will organize a talk on dog bite in my own colony. So I would request if this presentation can be shared with us, so we'll pick up whatever is relevant for the common public.
Surely. Yes.
Thank you. So my question is, one is, this was a logic which the practitioner used to apply, that if the rabid dog is, the rabid dog dies within 10 days from the transmissible period. So suppose if the dog is available for observation, so can we stop the vaccination at 3 doses, 0, 3, 7? This is my first question.
Yeah. You want me to answer and then you want to
Yeah,
ask the
please,
next
please.
question?
Yeah.
Yeah. So very, very important question. So that very much applies even now, the observation period of 10 days, but it applies only to dogs and cats, no other animals, because it is well studied only in dogs and cats. So if the dog or the cat, when it bites, it can transmit infection only if it is rabid at the time it is biting. So if it was rabid when it bites, it will die within a few days. It's 3 to 4 days, it will die. So the 10-day period is actually a higher limit. So it very much applies. But what we should do is, even if it is a pet dog, because you mentioned rightly, there might be your neighbor and neighbor will say, no, I have vaccinated my pet. In India, see, we as doctors, we are even legally liable. So it is our responsibility to still recommend PEP. So what we do is, we do not delay initiating PEP. We tell you start your PEP. But like you said, if the dog or the cat is alive by day 10, then they can omit the last 2 doses, which fall on day 14 and day 20. But under no circumstances should somebody wait for 10 days to initiate PEP, because uh, if at all the pet dies, then it is they develop serious anxiety, and we see so many such cases which we have to refer to our psychiatry. It is so bad, the fear, the phobia, and the anxiety. There are also when we say vaccination, even in pets, dogs especially, the rabies vaccination is an annual vaccination. So usually it is given only at 3 months of age, not before that. So people believe that puppies less than 3 months cannot transmit rabies. In fact, it's the opposite. Because the pets are vaccinated only at 3 months or above, smaller puppies are more vulnerable to get rabies and transmit rabies. Second, even if somebody says they are regularly vaccinating, we have seen, because we earlier used to test all dogs uh, which fly abroad. It is mandatory that not only they are vaccinated for rabies, but their titers should be checked. So earlier we used to do even for dogs. And we have seen exotic breeds being vaccinated, and yet there are no antibodies in their blood. So this can happen because one, the quality control of veterinary vaccines is not as good as human vaccines. Second, even animals may be immunocompromised because of, say, some helminthic infections, or they're not, uh, they're nutritionally deficient. There are so many reasons where, despite vaccination, they may not have an immune response. So when there are so many ifs and buts, it is always better to give the vaccine because it is one of the cheapest vaccines. It is around 400 rupees per dose. And if you all start using the intradermal technique, it costs some 30 to
Cheap.
40 rupees per dose. So that is the advice we give, and that is what I would tell you, sir, as well. Yeah.
Thank you, ma'am. Thank you. The second question is like you mentioned about the pre-exposure prophylaxis as give 3 doses, 0, 7, 21, oblique 28. So after that, booster is not required. That is what you said, no? So, but if they
Yes.
have a bite, then you give a full course or you just give 3 doses?
No, then you give
Full,
only 2 boosters.
only two, yeah, only two
Yes.
boosters. But
Anytime in life.
yeah. So, but I have seen the some of the veterinary doctors so recommending annual boosters for frequent animal handlers for their own staff and all these dog rescue teams and all.
Correct. So
Um,
very correct. So that is a high risk group. So for example, we work with the rabies virus as well. So what we do, anybody who comes, so even say veterinarians, handlers, our mortuary staff also we vaccinate because they may handle so many rabies cases, bodies of rabies patients as well. So what we do here is, so I had put it in my last slide. So in such cases, people who are continually at high risk, they have to get their titers checked uh, at least once a year. And if the titers are less than 0.5, they have to take booster. But what we generally do, the titer test also is not
expensive.
done. In fact, yes, NIMHANS is only one of the few centers who do, and the test itself takes 3 days. It's a cell culture based assay. So we just give annual boosters. So we all take 1 dose every year as a
Okay.
booster. But that is only for people who are continually at high risk, not for the general population.
Oh, got it. Thank you. Thank you so much.
Thank you, ma'am. And over to the next question. How to give immunoglobulin if mucosal exposure without any visible wound? It's already been discussed.
Yeah, so that's what I said, right? When there are mucosal exposures, we cannot infiltrate rig. Though there are some reports where people have rinsed the site with rig, but that is not a scientific recommendation, but people have used it. But in such cases is where we recommend intramuscular rig. So whatever is calculated as per the body weight can be fully injected intramuscularly in addition to vaccines.
Okay. If the dog is vaccinated and patient has category 2 or 3 bite, should we still go for immunoglobulin?
Yeah, so as I said, see, it is very risky for us to trust somebody because rabies doesn't give a second chance. It is once somebody gets, it's fatal. So unless I would only say, see, if they have records of their dog vaccination and you see that the dog is vaccinated annually, then you have to look at the brand of the vaccine. These are all too many things that somebody has to do. It is always better to recommend PEP. Start PEP, and then, like I said, if the pet dog or cat is alive by day 10, they can omit the last 2 doses, day 14 and day 20. See, at the most, it may not be beneficial for that exposure. But one, it doesn't cause any harm. And second, it will act as a pre-exposure. It will protect that person from any future exposures. So in fact, if we recommend anybody who gets a pet home, vaccinate the pet, and the family also can get a pre-exposure. Because usually people who have pets, they are animal lovers, they may come in contact with other animals. Children especially, they like animals, they may go and touch stray dogs, come in contact with them, and they don't even come and tell home. They will never tell their parents. They might hide. So in such cases, a pre-exposure is the best option. There is no case in the entire world where somebody has developed rabies after having a pre-exposure vaccination. Though we still have at least some cases which develop rabies despite post-exposure. Like I said, if there is a very deep bite directly where the virus is inoculated in the nerves, pre-exposure is the best method to save ourselves from rabies. So at least people who afford should be given that option.
Okay, ma'am. Dr. Neelam has a question. Does pre-exposure prophylaxis render immunity for life? If yes, why are 2 doses needed if a bite occurs?
Yes, so very good question. See, so as I said, if we measure the titers, generally the following, say, 3 or 4 doses, the titers will increase, peak by 3 to 6 months, and then start falling down. So by the end of 1 year, you may not find any measurable antibody titers. But the memory B cell response, like we have for all other childhood vaccines, right? So that is going to remain lifelong. And therefore, we give a booster, because when we give a booster, the secondary immune response, the anamnestic response that we call, is immediately very high. And this is a cautionary step that we follow, because this is rabies, which is fatal. So even the 5 doses, if you see the current WHO recommendations, even post-exposure prophylaxis now is only 4 intramuscular doses or 3 intradermal doses. But in India, we are still continuing with 5 intramuscular and 4 intradermal, because we are being overcautious. So that is the reason which we give. Second point, remember, a rabies vaccine is a killed vaccine. And therefore, there is a requirement of boosters.
Thank you, ma'am, for that clarification. If eyes are contaminated with saliva, do we give Rick as eye wash?
Yeah, so it has been read. So first is
this.
thorough washing with water. The area should be flushed with water. Second, there is no recommendation as such that it can be rinsed with rabies immunoglobulin. But as I said earlier, you can give vaccines and give intramuscular rig.
Okay. Is immunoglobulin absolutely contraindicated when a person has already received pre-exposure prophylaxis? Will it interfere with immune response? I would also add another question. Madam, can you please comment? Nowadays, many patients are on chemotherapy medications or immunosuppressants, steroids, or they have retropositive status. So, in these scenarios where the immunity is challenged, will pre-exposure prophylaxis protect a patient from getting rabies after an exposure?
Yes, so again, both the questions are very good. I'll answer your question first. So yes, such people can be given pre-exposure prophylaxis. And if they have exposure, it's the same. You can just give them 2 boosters. So that will apply even in immunocompromised patients. See, remember, even in immunocompromised patients, we have rarely seen rabies vaccine failures. Unlike, say, a hepatitis B vaccine, where we see a lot of non-responders. In rabies, in our practice, we have not seen. But yes, but anyway, we are giving 2 boosters also, following a pre-exposure whenever there is a re-exposure. Then coming to the first question, whether REG is absolutely contraindicated. See, that's a very good question. In rabies, there are so many scenarios that you won't have a written explanation for everything. So, for example, if say somebody, we have seen such cases with people call us. So when the patient has come, a child has come first, there was a category 3 bite, he was given vaccine and he was given RIC. Now, after about 7 days, the mother found that the child had one more wound, which none of them had seen for the first time. So in such cases now, we said, yes, it is better to give, though it was past the 7 days. We said, yes, it is safer to give infiltration there as well. So yes, it's not an absolute contraindication, but it will not help much because the active immune response has started. It is said theoretically it can interfere with the active immune response, but generally we have seen that it drastically does not impact the antibody titers. So when in doubt, you can always give.
Thank you, ma'am. In a patient who has received full 5 doses of vaccine previously and has now come in after a category 3 bite several months later, should they get 3 doses or 5 doses of vaccine?
So they should get only 2 boosters, day 0 and day 3. If it is beyond 3 months, if it is within 3 months of their 5 doses, then nothing has to be done.
Okay.
So whatever category this applies, like 2 boosters, day 0 and day 3, provided you are sure that they have a documentation that they have taken all 5 doses previously. So that is very important. Yeah.
Okay. Immunization schedule for immunized dog bite.
Yeah, so I think I have
Yeah,
already
we have
explained. Yeah, it is too risky to say don't take PEP. Otherwise, then you all have to investigate. In fact, even some people even get the titers of their dogs done first. But
Yes.
even in dogs, it takes 3 to 4 days for the test to come. We cannot wait until then. So it is better to just take one.
Start.
Yes, start the PEP. And the test is, by the way, more costly than
I
a
think
vaccine
after
dose.
hearing your talk, and the wait and watch period is even more taxing to all of us, especially because we are family physicians. We have to look into their mental health as well, and they become
Yes,
extremely anxious. It's very,
yes.
very difficult to counsel, especially in case of children and young adults. The parents are more anxious, and we have seen many such scenarios.
Yeah, I
Uh,
must also mention, since you said this, because we are seeing now increasing cases of this anxiety phobia following dog bite. So we have a NIMHANS has a telemanus number. I can send it
yes,
later.
yes.
So we have now some staff specifically trained to handle such cases, the fear,
Oh,
anxiety, phobia following dog bites. So y'all can directly refer such patients to the telemanus if they feel, because they will evaluate them telephonically, and then if they feel, they will even call them to NIMHANS if they feel that they require in-person evaluation and treatment. I will send across that number.
sure, sure, sure. Thank you so much, ma'am, and also Nimans for that. And Dr. Shabana has a comment. Today she got a case of monkey scratch. So I think she wants to know if there is a possibility of rabies. Because monkeys, I don't know how they behave with rabies because they are monkeys. So very difficult to
Yes.
find out.
Yes. So usually, see, we know that it is because now we see a lot of monkeys in urban areas. So for food
Yes,
and
ma'am.
this, they come and bite. But having said that, we have proven lab confirmed cases of rabies acquired from monkeys in
Oh,
India. So same. So we will. The advice is that yes, you have to take PEP. That is the recommendation, national recommendation as well. Same.
okay. Okay. Your comment about category 2 bites pregnancy is required.
So just before
Uh,
that, Swami, I just wanted to add regarding the scratch, no? People consider scratch as not a bite. They say that the rabies virus is transmitted through saliva. So why should scratch be considered as bite? So mostly, if you see the behavior of the animal, they keep licking the nails and all. So that is another logic to consider scratch as a bite. So
Yes,
saliva is there.
I mentioned it as well because it is category 3 because they lick their paws and it is deposited. Yes.
And
Yeah,
what
your
about your
question.
comments about bites during pregnancy and safety profile of immunoglobulin administration, the risk versus benefits?
Yeah, so see, the question was in category 2. So I don't think in pregnancy you can treat it as a category 2 and give only vaccines. But even if there's a category 3 bite in pregnancy, you have to give. So far the safety profile has been good, but do we have a choice? We have, I mean, I feel so sad to this incident. A few years ago, it happened. It was a woman in Chennai. She was from a very well educated, well off family. She had conceived following 3 cycles of IVF, and it was a precious pregnancy. In her second trimester, she was bitten by a stray dog. She went not to one but two gynecologists, and both of them advised it's a precious pregnancy, no need for PEP. In her third trimester, she developed rabies. The child was delivered by cesarean. It survived. Luckily, the woman died on the day of rabies. So even now, if in our country such things are happening, therefore I mentioned there is no contraindication for rabies post-exposure prophylaxis. We can deal with whatever side effects are there. We can deal with it, but we cannot avoid it.
If a person who was previously fully vaccinated, not given immunoglobulin in the past, present with category 3 bite, what's the treatment protocol?
Yeah, so very good question. See, anybody who is vaccinated earlier, even with or without rig, they have developed immunity, they have memory B cells. So they do not need a rig in any of their exposures subsequently in their life because they already have the memory cells. So as soon as you give a booster, within 2 to 3 days, the antibody response goes up. The secondary response is very fast, unlike the primary antibody response, which takes 1 to 2 weeks. So even if earlier they have not got that, that is the advantage of pre-exposure prophylaxis. No, you only take 3 doses of vaccines, and then for the rest of your life, any exposure, you don't need rabies immunoglobulin. You need only 2 boosters if you get an exposure.
I think after hearing your talk, all of us should motivate our patients to take, the vaccine as a pre-exposure prophylaxis, not to make it
Yes.
optional. I think we should insist because the long-term benefits of taking the vaccine far outweighs not taking the vaccine and taking it after an exposure. I think
Yes. In
we have a
fact, the
lot of
government is
comments
considering,
about the session being wonderful. I think yes.
yeah,
Hmm.
so in fact, the government is considering also introducing rabies pre-exposure as a part of the universal immunization. Some states like Kerala is also seriously considering implementing it in their state. But until then, at least, when we are advising other non the vaccines which are not included in universal immunization chip, which are so costly, at least we should give that option to parents.
Yeah, we have few more questions. Is it correct that exposure with wild animals, monkey considered as category 3, even if it is if
Yes, yeah.
it
So our
scratches? Yeah.
Indian guidelines, yes, the WHO guidelines do not mention like that, but our Indian guidelines say any wild animal exposure treated as category 3. WHO also says that any bat exposure, uh, consider it as category 3 because bat bites and exposures are extremely superficial. You will not even know that a bat has bitten you. But in India, we don't have the guideline because, as I said, in India, we do not have adequate evidence to suggests that bats can transmit rabies to humans, and therefore, see, it is a public health guideline. But on an individual basis, you all can decide based on the anxiety of the person, based on what was the scenario where that exposure happened. If somebody has gone in the forest and they were bitten, all these are things that you should take a call based on that. And it is always better to overtreat than undertreat in rabies. This is something you all
Yes,
should all
ma'am.
remember.
Yes, yes. I think there are a lot of comments pouring in about the best presentation on rabies ever. Thank you for sharing the knowledge. And many of them have mentioned, no, it's from our heart. The moment I heard your talk in Kolkata, I was always thinking I should have ma'am in our one of the webinars as presentation. And somehow I lost your number and got reconnected. Today, I'm very grateful that many of them are making good use of it. And I think it's been 1.5 hours. I think I don't know how we have crossed it. I'm sure many of them have still more questions. There is one more. What is the benefit of giving TT? It works after 4 weeks. I think he meant that even we recommend TT because whenever there is a bite, sometimes there is an associated sand exposure. So
Yes, so TT should be given, but depending on like what is their previous status of TT. Yeah.
yeah. Dr. Hema is around, our secretary from AFPI. I think we are truly very, very grateful to this wonderful session. Over to Dr. Hema. She is Associate Professor at St. John's. Yes, Hema.
Thank you, Dr. Soumya. And thank you very much, ma'am. This was very enlightening and very engaging session. And thank you, Dr. Soumya, for picking up this very, very important topic and organizing. Thank you to you and Dr. Madhumita. And thank you all for joining in this large number. We didn't expect this number during the working days. We never had such numbers, I think, before. Yeah,
Yeah.
that says it all. So
That
thank you all.
about Rita Madam. She's very, very
Yeah,
popular, and now she is very popular in AFPI also. We would love to hear more, and if there is a personal email or anything where we can interact with you for some difficult, challenging cases, I think that will be of great help. And also, we need that helpline number you said. Yes.
Yeah, I have put my email already. Anybody is free to contact me on that.
Thank you, ma'am.
thank you, ma'am. Thank you for your support. And
Yes,
thank you
thank
all
you so
for
much.
joining in and participating actively. Thank you, Dr.
Yeah.
Soumya.
Thank you, Rita ma'am. It's been a long day, but it was a very fruitful day. I would say that the first thing we all, as family physicians, would go and do is advise them on
Yeah.
rabies as an optional vaccine, as a pre-exposure prophylaxis. That's the most important take-home message. I never had given so much of weightage until today. Thank you.
Yes. Thank you so
Thank you.
much. It was a
Thank you,
wonderful
ma'am. Good
audience
night.
also. So I really